It is now time to shift our focus on sodium and water balance. In this picture, which is very similar to the one found in your textbook, you see that we consume and release roughly 2.5 liters of fluid a day. On the left you are seeing our daily intake, and on the right our daily output. Notice most of our fluid intake comes from drinking, followed by water content in the food we eat, and also we get water as a byproduct of metabolism. Most of the way we void water from our body is through urine, then insensible water loss, that means evaporation of water through our skin and lungs, followed by water lost in sweat, and then our feces. Clearly, if your output is greater than your input, you will become dehydrated. And if your input is greater than your output, then your blood volume and pressure will rise. As already mentioned, water accounts for 50 to 70% of body weight, with an average value of 60%. The percentage of total body water varies depending on gender and the amount of adipose tissue in the body. Water content of the body correlates inversely with fat content. Women have lower percentages of water than men because women have the higher percentage of adipose tissue. For these reasons, thin men have the highest percentage of body weight as water, about 70%, and obese women have the lowest percentage, about 50%. The relationship between water content and body weight is clinically important, since changes in body weight can be used to estimate changes in body water content. For example, in the absence of other explanations, a sudden weight loss of 3 kilograms reflects a loss of 3 kilograms, or roughly 3 liters, of total body water. Intracellular fluid is the water inside the cells in which all intracellular solutes are dissolved. Briefly, the major cations are potassium and magnesium, and the major anions are proteins and organic phosphates, such as adenosine triphosphate, adenosine diphosphate, and adenosine monophosphate. The composition of the extracellular fluid differs substantially from the intracellular fluid. The major cation of the ECF is sodium, and the major anions are chloride and bicarbonate. Plasma is an extracellular fluid and is the aqueous component of blood. Plasma proteins constitute about 7% of plasma by volume. Thus, only 93% of plasma volume is plasma water, a correction that is usually ignored. Interstitial fluid is an ultrafiltrate of plasma. It has nearly the same composition as plasma, excluding plasma proteins and blood cells. To understand why interstitial fluid contains little protein and no blood cells, simply remember that it is formed by filtration across capillary walls. Pores in the capillary wall permit free passage of water and small solutes, but these pores are not large enough to permit passage of large protein molecules or cells. There are also small differences in the concentration of small cations and anions between interstitial fluid and plasma, explained by the Gibbs-Donnan effect of the negatively charged plasma proteins. The Gibbs-Donnan effect predicts that plasma will have a slightly higher concentration of small cations than interstitial fluid and a slightly lower concentration of small anions. ADH, or vasopressin, is the major hormone concerned with regulation of body fluid osmolarity. ADH is secreted by the posterior pituitary, but made by the hypothalamus, in response to an increase in serum osmolarity. ADH then acts on the principal cells of the late distal tubule, collecting duct, and the inner medullary duct cells to increase water reabsorption. Thus, it will decrease body fluid osmolarity back toward normal. I will go through this mechanism on the molecular level on the next slide. The second action of ADH is to cause contraction of vascular smooth muscle, as implied by its other name, vasopressin. The receptor for ADH on vascular smooth muscle is a V1 receptor, which is coupled to phospholipase C via a G protein. The second messenger for this action is IP3-DAG and calcium, which produces contraction of vascular smooth muscle, constriction of arterioles, and increased total peripheral resistance. Those of you from my physiology class, you are now probably breaking out in hives by me just mentioning second messenger systems, aren't you? Let's have a brief discussion on urea. Urea is freely filtered across the glomerular capillaries, and the concentration in the initial filtrate is identical to that in blood. That is, initially there is no concentration difference or driving force for urea reabsorption. However, as water is reabsorbed along the nephron, the urea concentration in tubular fluid increases, creating a driving force for passive urea reabsorption. Therefore, urea reabsorption generally follows the same pattern as water reabsorption. The greater the water reabsorption, the greater the urea reabsorption, and the lower the urea excretion. In the proximal tubule, 50% of the filtered urea is reabsorbed by simple diffusion. As water is reabsorbed in the proximal tubule, urea lags slightly behind, causing the urea concentration in the tubular lumen to become slightly higher than the urea concentration in blood. This concentration difference then drives passive urea reabsorption. At the end of the proximal tubule, 50% of the filtered urea has been reabsorbed. Thus, 50% remains in the lumen. In the thin descending limb of Henle, the loop, urea is secreted. By mechanisms that will be described later in the course, there is a high concentration of urea in the interstitial fluid of the inner medulla. The thin descending limb of Henle's loop passes through the inner medulla, and urea diffuses from high concentration in the interstitial fluid into the lumen of the nephron. More urea is secreted into the thin descending limbs than what was reabsorbed in the proximal tubule. Thus, at the bend of the loop of Henle, 110% of the filtered load of urea is present. The thick ascending limb of Henle, the distal tubule, and cortical and outer medullary collecting ducts are impermeable to urea. Thus, no urea transport occurs in these segments. However, in the presence of antidiuretic hormone, water is reabsorbed in the late distal tubule and the cortical and outer medullary collecting ducts. Consequently, in these segments, urea is left behind, and the urea concentration of the tubular fluid becomes quite high. In the inner medullary collecting ducts, there is a specific transporter for the facilitated diffusion of urea. This is the urea transporter 1, or UT1. This is activated by ADH. Thus, in the presence of ADH, urea is reabsorbed by UT1, moving down its concentration gradient from the lumen into the interstitial fluid of the inner medulla. That is what I meant by more urea is present in the inner medulla and can actually be secreted into the loop of Henle. In the presence of ADH, approximately 70% of the filtered urea is reabsorbed by UT1, leaving 40% of the filtered urea to be excreted in the urine. The urea that is reabsorbed into the inner medulla contributes to the corticopapillary osmotic gradient in a process called urea cycling. This will be addressed in later sections when we talk about pathophysiology of the renal system, but you might also want to review this online with the interactive physiology videos that I posted for week 11. ADH vasopressin has two actions, one on the kidney and the other on vascular smooth muscle. These actions are mediated by different receptors, different intracellular mechanisms, and different second messengers. First, let's address the increase in water permeability. The major action of ADH is to increase the water permeability of principal cells in the late distal tubule, collecting duct, as well as the cells of the medullary duct. The receptor for ADH on the principal cells is the V2 receptor, which is coupled to adenylyl cyclase via a G protein. The second messenger used is cyclic AMP, which, through phosphorylation steps, directs the insertion of water channels, aquaporin 2 specifically, in the luminal membranes. The increased water permeability of the principal cells allows water to be reabsorbed by the collecting ducts and makes the urine concentrated, or hyperosmotic. Two questions need to be answered. How is urine rendered hyperosmotic? Urine becomes hyperosmotic in the presence of ADH by equilibration of tubular fluid in the collecting ducts with a high osmolarity of the corticopapillary gradient. The corticopapillary osmotic gradient is established by countercurrent multiplication, a function of the loops of Henle, and by urea recycling, which I just mentioned in the previous slide. This is a function of the intermedullary collecting ducts, the urea recycling. In the late distal tubule, the principal cells are permeable to water in the presence of ADH. Recall that fluid entering the late distal tubule is quite dilute, about 80 milliosmol. Since the cells are now permeable to water, water flows out of the tubular fluid by osmosis, driven by the osmotic gradient across the cells. That is, it is reabsorbed. Water reabsorption will continue until the tubular fluid equilibrates osmotically with the surrounding interstitial fluid. The tubular fluid leaving the distal tubule is equilibrated with the interstitial fluid of the cortex, and it has an osmolarity of about 300 milliosmol. In the collecting ducts, the mechanism is the same as that described in the late distal tubule. The principal cells of the collecting ducts are permeable to water in the presence of ADH. As tubular fluid flows down the collecting ducts, it is exposed to interstitial fluid with increasingly higher osmolarity, that is, the corticopapillary osmotic gradient. Water will be reabsorbed until the tubular fluid equilibrates osmotically with surrounding interstitial fluid. How high will the urine osmolarity be? The final urine will reach the osmolarity present at the tip of the papilla, which in this example is 1200 milliosmol. Increased plasma osmolarity is the most important physiologic stimulus for increasing ADH secretion. For example, when a person is deprived of water, serum osmolarity increases. The increase is sensed by osmoreceptors in the anterior hypothalamus. Action potentials are initiated in cell bodies of the nearby ADH neurons and propagated down the axons, causing the secretion of ADH from nerve terminals in the posterior pituitary. Conversely, decreases in serum osmolarity signal the hypothalamic osmoreceptors to inhibit the secretion of ADH. Hypovolemia, or volume contraction, for example due to hemorrhage, is also a potent stimulus for ADH secretion. Decreases in extracellular fluid volume of 10% or more cause a decrease in arterial blood pressure that is sensed by baroreceptors in the left atrium, carotid artery, and aortic arch. This information about blood pressure is transmitted through the vagus nerve to the hypothalamus, which directs an increase in ADH secretion. ADH then stimulates water reabsorption in the collecting ducts, attempting to restore extracellular fluid volume. Importantly, hypovolemia stimulates ADH secretion even when plasma osmolarity is lower than normal. Conversely, hypervolemia, volume expansion, inhibits ADH secretion, as I will show you on the next slide, even when plasma osmolarity is higher than normal. Pain, nausea, hypoglycemia, and various drugs, for example, nicotine, opiates, and anti-neoplastic agents, all stimulate the secretion of ADH, along with a few others I have listed here. Ethanol, alpha-adrenergic agonists, and atrial natriuretic peptide inhibit secretion of ADH. The biggest stimulus to inhibit ADH release is reduced blood osmolarity and increased blood volume. Along with increased blood volume would come increased blood pressure, and this too inhibits ADH release. Central diabetes insipidus. Let's talk about that. Central diabetes insipidus can follow head injury in which trauma depletes the posterior pituitary gland of ADH stores. The posterior pituitary is, therefore, unable to secrete ADH in response to an osmotic stimulus. Because circulating levels of ADH are low or zero, the entire distal tubule and collecting ducts are impermeable to water. Hence, large volumes, as much as 15 liters a day, of very dilute urine are excreted. Plasma osmolarity increases to abnormally high values as excessive amounts of water are excreted in the urine, water that would have been reabsorbed if ADH were present. The high plasma osmolarity would normally stimulate ADH secretion, but in central diabetes insipidus, there is no ADH to be secreted from the posterior pituitary gland. Treatment of central diabetes insipidus consists of administration of an ADH analog, such as 1-deamino-8-D-arginine vasopressin, abbreviated as DDAVP. Nephrogenic diabetes insipidus involves a defect in the response of the kidneys to ADH. Although ADH secretion from the posterior pituitary gland is normal, a defect in the receptor, the G protein, or adenylyl cyclase, makes the principal cells unresponsive to ADH. As a result, ADH fails to increase water permeability in the late distal tubule and collecting ducts. As in central diabetes insipidus, water cannot be reabsorbed by these segments, and large volumes of dilute urine are excreted. The plasma osmolarity increases, which stimulates the posterior pituitary to secrete even more ADH. Circulating ADH levels are higher than normal in nephrogenic diabetes insipidus, but these high levels of ADH still are ineffective on principal cells. Nephrogenic diabetes insipidus is treated with thiazide diuretics. Administration of an ADH analog, such as DDAVP, would be futile, as the defect lies in the response to ADH. To understand the rationale for using thiazide diuretics, first consider the fundamental problem in nephrogenic diabetes insipidus. Because the principal cells are unresponsive to ADH, there is excretion of large volumes of dilute urine. Thiazide diuretics are helpful as follows. 1. They inhibit sodium chloride transport in the early distal tubule, thereby preventing dilution of the urine in this segment. As more sodium chloride is excreted, the urine is less dilute than it would be without treatment. 2. Thiazide diuretics produce a decrease in GFR, and, secondary to decreased sodium reabsorption, a decrease in extracellular fluid volume. The decrease in ECF volume causes an increase in proximal tubule reabsorption via effects on Starling forces. The combination of less water filtered and more water reabsorbed in the proximal tubule means that the total volume of water excreted is decreased. As previously described, the appropriate response to water deprivation is production of hyperosmotic urine, shown here in the far right picture of the 3 urine tubes. However, in the syndrome of inappropriate ADH, or SIADH, hyperosmotic urine is produced inappropriately. In SIADH, circulating levels of the hormone ADH are abnormally high, owing to either excessive secretion from the posterior pituitary following head injury, or secretion of ADH from abnormal sites such as lung tumors. In these conditions, ADH is secreted autonomously without an osmotic stimulus. In other words, ADH is secreted when it is not needed. In SIADH, the high levels of ADH increases water reabsorption by the late distal tubule and collecting ducts, making the urine hyperosmotic and diluting the plasma osmolarity. Normally, a low plasma osmolarity would inhibit secretion of ADH. However, in SIADH, this feedback inhibition does not occur because ADH is secreted autonomously. Treatment of syndrome of inappropriate ADH consists of administration of a drug such as demeclocycline, which inhibits the ADH action on the renal principal cells, or the use of an isoosmotic diuretic such as mannitol, which I will discuss now. Mannitol is a 6-carbon sugar alcohol. Mannitol is an osmotic diuretic. Mannitol occurs naturally in fruits and vegetables and is metabolically inert in humans. After intravenous injection, it is confined to the extracellular space, metabolized only slightly, and excreted rapidly by the kidneys. Approximately 80% of a 100-gram dose appears in the urine in 3 hours. Mannitol is freely filtered by the glomeruli with less than 10% tubular reabsorption. It is not secreted by tubular cells. It induces diuresis by elevating the osmolarity of the glomerular filtrate and thereby hinders tubular reabsorption of water. Particles suck, remember. Urinary output of water and excretion of sodium and chloride are enhanced. Mannitol is poorly absorbed from the gastrointestinal tract, which is why it has to be given by IV versus eaten. Of all the functions in the kidney, reabsorption of sodium is the most important. Consider that sodium is the major cation of the extracellular fluid compartment, which consists of plasma and interstitial fluid, and the transcellular fluid. The amount of sodium in the ECF determines the ECF volume, which in turn determines plasma volume, and blood pressure. The renal mechanisms involved in reabsorption of sodium, that means returning sodium to the ECF after filtration, therefore, are critically important for the maintenance of normal ECF volume, normal blood volume, and normal blood pressure. The kidneys are responsible for maintaining a normal body sodium content. On a daily basis, the kidneys must ensure that sodium excretion exactly equals sodium intake, a matching process called sodium balance. For example, to remain in sodium balance, a person who ingests 150 milliequivalents of sodium daily must excrete exactly 150 milliequivalents of sodium daily. If sodium excretion is less than sodium intake, then the person is in positive sodium balance. In this case, extra sodium is retained in the body, primarily in the ECF. When the sodium content of ECF is increased, there is increased ECF volume, or we call this ECF volume expansion, blood volume, and arterial pressure also increase, and there may be edema. Conversely, if sodium excretion is greater than sodium intake, then a person is in negative sodium balance. When excess sodium is lost from the body, there is a decreased sodium content of extracellular fluid, decreased ECF volume, or this is called ECF volume contraction, and this leads to decreased blood volume and arterial pressure. An important distinction should be made between sodium content of the body, which determines ECF volume, and sodium concentration. Sodium concentration is determined not only by the amount of sodium present, but also by the volume of water. For example, a person can have increased sodium content, but a normal sodium concentration if and when water content is increased proportionally. Or a person can have an increased sodium concentration with a normal sodium content if water content is decreased. In nearly all cases, changes in sodium concentration are caused by changes in body water content rather than sodium content. The kidney has separate mechanisms for regulating sodium and water reabsorption. The actions of mineralocorticoids, for example, aldosterone, are described here. Briefly, aldosterone has 4 actions on the late distal tubule and collecting ducts of the kidney. 1. It increases the gene expression and insertion of more sodium-potassium ATPases in the basolateral cell membranes of the principal cells in the late distal convoluted tubule. More activity of this pump will ensure a better driving force for sodium reabsorption through the apical membrane by maintaining a low intracellular sodium level. 2. It increases sodium reabsorption through the apical membrane by increasing the gene expression and insertion of sodium channels in the apical membrane. 3. It increases potassium secretion through the synthesis of more potassium channels on the apical membrane to allow potassium to diffuse out of the cell down its concentration gradient. And 4. It increases hydrogen secretion. Its effects on sodium reabsorption and potassium secretion are on the principal cells, and its effect on hydrogen secretion is on the alpha intercalated cells, the other cells found in the late distal convoluted tubule. Thus, when aldosterone levels are increased, for example, due to an aldosterone-secreting tumor, sodium reabsorption, potassium secretion, and hydrogen secretion are all increased. These changes in renal transport result in extracellular fluid volume expansion, hypertension, hypokalemia, and metabolic alkalosis. Conversely, when aldosterone levels are decreased, for example due to adrenal insufficiency, sodium reabsorption, potassium secretion, and hydrogen secretion are all decreased. These changes produce extracellular fluid volume contraction, hypotension, hyperkalemia, and metabolic acidosis. An interesting quote problem arises with respect to the actions of mineralocorticoids in their target tissues, for example, the late distal tubule and collecting ducts of the kidney. That is, the affinity of mineralocorticoid receptors for cortisol is surprisingly just as high as their affinity for aldosterone. As circulating levels of cortisol are much higher than circulating levels of aldosterone, it seems that cortisol would overwhelm and dominate the mineralocorticoid receptors. How would the kidneys know that a change in aldosterone concentration had occurred and that mineralocorticoid actions are desired if the receptors are blocked by cortisol? The problem is solved by the renal cells themselves. They contain an enzyme called 11-beta-hydroxysteroid dehydrogenase, which converts cortisol to cortisone. In contrast to cortisol, cortisone has a very low affinity for mineralocorticoid receptors. In this way, cortisol is effectively inactivated in mineralocorticoid target tissues. This unique solution allows changes in blood levels of aldosterone to be, quote, seen by the renal cells and not be overshadowed by the high circulating levels of cortisol. This inactivation of cortisol in mineralocorticoid target tissues also explains why, when circulating levels of cortisol are high, the cortisol has only weak mineralocorticoid activity, despite its high affinity for mineralocorticoid receptors.